Our next and last presenter really needs no introduction. She is the president of the Arabic Association of the Diabetes and Metabolism. She's a professor of internal medicine and diabetology at Cairo University, member of many associations, including the European Association for the Study of Diabetes, the Egyptian Society of Medicine, the Egyptian Society of Diabetes, and a member of the Egyptian Medical Association studying obesity, EMASO. She has been working tirelessly to provide high quality, world-class education for not only Egypt, but the whole Arabic world. It is my pleasure and honor to introduce our president, Dr. Inass Shaltout. Dr. Shaltout, please.
Thank you very much, Professor Andrew, for the nice presentation. And it's challenging to speak after Muhammad and after Professor George in this session. I'm going to talk about sarcopenia and cardiometabolic risk. And sarcopenia is a Greek word, means lack of flesh. Sarcopenia is recognized recently as a geriatric syndrome, means age-related loss of muscle mass and muscle function. Studies show that there is association between sarcopenia and adverse health outcomes, such as falls, disability, hospital admission, medical care requirement for a long time, poor quality of life, and mortality. Again, it is a Greek name, means lack of flesh. There is loss of muscle mass and strength with aging. And in this figure, there is the percentage of muscle loss with aging, comparing those at the age of 35 to those older at the age of 45. And those at the age of 75, we can find loss of muscle mass and loss of muscle strength. After the age of 50, approximately 1 to 2% of the muscle mass is lost per year. But after the age of 60, there is loss of 3% of muscle mass every year and decrease in muscle strength of 1.5% annually after the age of 60. These are the changes in body composition associated with aging. They include gradual decrease in muscle mass, especially of the lower extremities, and increase in fat volume, especially visceral fat and intermuscular fat. This is the prevalence of sarcopenia. Some studies say that we have sarcopenia in 10 to 40% of the global population, and increasing lifespan of the global population in the last centuries led to higher percentage of people above the age of 65. This led to increase in age-related conditions such as sarcopenia and diabetes. Globally, in 2020, people older than 65 were 9.3% of the total population and expected by 2050 to have 1.5 billion persons with age above the age of 65. This is the 2019 operational definition of sarcopenia. We have criterion number 1, which is low muscle strength, criterion number 2, which is low muscle quantity or quality, and criterion number 3, which is low physical performance. And there is probable sarcopenia diagnosis if we have only criterion 1, and diagnosis is confirmed by additional documentation of criterion 2. And if we have criterion 1, 2, and 3, then sarcopenia is considered severe. These are some pathophysiological factors leading to sarcopenia: decreased physical activity, some endocrine factors, muscle atrophy, decreased protein synthesis, insulin resistance, mitochondrial dysfunction, malnutrition, autophagy, and some DNA abnormality. These, again, are some multifactorial pathogenetic disorders leading to sarcopenia. Decreased level of sex hormone, for example, testosterone and GHEA, decreased level of growth hormone and insulin-like growth factor 1, increased cytokine production like interleukin 1, interleukin 6, tumor necrosis factor, some musculoskeletal changes, smoking, physical inactivity, malnutrition, especially protein deficiency. These are the changes in muscle function in sarcopenia. There is preferential loss of type 2 fibers leading to. Some of these symptoms and signs, you see them in your patients: difficulty in walking, in stair climbing, rising from the chair, gait problems, and load carrying deteriorates. There is loss of independence, increased risk of falls, and decreased basal metabolic rate, which leads to something called middle-age overweight. This is a decrease in lean muscle mass associated with age, together with increase in total lipid store. We can find that the muscle mass is reduced by age, and the fat stores are increased by age. And again, this is the muscle before and after sarcopenia. Before sarcopenia, to the left side, we can find with the right side that the fat mass is increasing and the muscle mass is reduced. But sarcopenia is not wasting. Wasting means loss of weight due to inadequate nutrition. And sarcopenia is not cachexia. Cachexia is loss of fat-free mass from hypermetabolism and hypercatabolism. And in disuse atrophy or acute disuse atrophy, the muscle mass is reduced, but the muscle fiber number and force is maintained. Older women with type 2 diabetes are especially at high risk of loss of skeletal muscle mass. How does insulin resistance cause sarcopenia? Through increased protein catabolism and decreased protein synthesis in the skeletal muscle. Again, this is the pathophysiological factors relating type 2 diabetes to sarcopenia. In type 2 diabetes, there is insulin resistance, chronic inflammation, accumulation of advanced glycated end products, and increased oxidative stress. They can negatively affect the skeletal muscle mass, strength, and function. There is decreased muscle mass and higher prevalence of sarcopenia in diabetic patients compared to non-diabetic patients. And also, patients with sarcopenia are at increased risk for developing diabetes. Then the relationship is bidirectional. Several papers established a reciprocal relationship between diabetes and sarcopenia. Sarcopenia prevalence is 2 to 3 times higher in diabetic patients compared to healthy controls, and vice versa. The factors relating the two conditions to each other, we said some of them like insulin resistance, altered metabolism, advanced age, increased adiposity, obesity, inflammation, oxidative stresses, mitochondrial dysfunction, advanced glycated end products, vascular complications, muscle atrophy, reduced muscle quality and function, myopathy, and lifestyle in the form of poor exercise and poor diet. Again, this is a figure relating the pathophysiological causes of sarcopenia to those with diabetes, the interrelation between both of them. How to screen for sarcopenia? For older individuals, we start with measurement of the gait speed. If the gait speed is less than 0.8 meter per second, we measure the grip strength. If normal, there is no sarcopenia. If low, we shift to the other side, to the right side. When we measure gait, and we found gait speed, and we found the gait speed more than 0.8 meter per second, then we measure the muscle mass. If the muscle mass is low, there is sarcopenia. If the muscle mass is normal, there is no sarcopenia. Then it depends mainly on two factors, the gait speed and the strength of the hand grip. Sarcopenia has a potential health concern in women. The rate of decline in strength are twice higher in men compared to women. And men have higher amount or larger amount of muscle mass, and men have a shorter survival than women. We come now to hypertension. What is the relation between hypertension and sarcopenia? Hypertension is a major public health problem, and it is linked to insulin resistance. Insulin resistance exacerbates muscle strength loss, and insulin resistance contribute to hypertension, and these are the pathophysiological mechanisms linking hypertension to insulin resistance. Enhancement of tissue angiotensin II and aldosterone activity, increased sympathetic nervous system activity, oxidative stresses, and a new phenomenon known as endothelial insulin resistance. The prevalence and factors associated with sarcopenia among elderly individuals, this is a published research, found that the overall prevalence of sarcopenia among elderly individuals with hypertension was 20%. This is compared to the global prevalence of sarcopenia, which is considered to be 10%. Then there is increased incidence of sarcopenia in hypertension twice compared to non-hypertensive persons. Inside the study discussion, the study found a very high prevalence of sarcopenia among elderly individuals with hypertension, and the current research confirms that sarcopenia is associated with hypertension, and the possible mechanism is that hypertension can lead to the production of related catabolic cytokines. Chronic inflammation, catabolic factors remain the most widely accepted mechanism relating hypertension to sarcopenia. Muscle mass and function decline with age. This is considered a normal phenomenon, but it can happen rapidly and progressively in the setting of chronic conditions such as hypertension. And this is, again, the relationship between sarcopenia and cardiovascular disease. Both of them may have same etiological defects, and both of them are linked to each other. Cardiovascular disease can lead to sarcopenia, and sarcopenia can lead to more prevalence of cardiovascular disease. Another link between vitamin D and sarcopenia in a study called the longitudinal aging study done in Amsterdam found that lower vitamin D and higher parathyroid hormone increase the risk of sarcopenia in older women. Another study, the Inshaanchi study, found that low vitamin D was associated with poor physical performance among elderly women. Let me now finish with this important slide. What is the treatment of sarcopenia, which can be either preventive or curative? Preventive is regular exercise from the early life. Then we should push our children, our young persons to make regular exercise from early life, not to stay till they are geriatric with sarcopenia and already muscle loss. After advancing age. This is helping to reduce sarcopenia incidence and sarcopenia progression, resistance exercise to prevent or reverse muscle loss, aerobic activity in the form of walking, cycling, golfing, and swimming, lifestyle modification, nutritional modification in the form of adequate protein intake, carbohydrate, and fiber, and stress-free environment whenever possible, functional and active daily schedule. Thank you very much.
Thank you, Inass. That was absolutely superb, very clear and very informative. Thank you. Has anybody got a pressing question?
Please come up in the microphone to give your question. Yes, please.
To Dr. Muhammad Hassanin. We know that diabetes early is a silent disease, and in most cases there is pre-diabetes, insulin resistance, and we face patients always with complications. We can't guarantee when diabetes starts. We can't calculate the beginning of diabetes أو pre-diabetes أو insulin resistance, and always we face those complications. ده يعني المحاضرة حضرتك اديتها يعني الغالب ان احنا مش هنقدر نعرف الايدج من قد ايه وكده بالنسبة لتايب 2 diabetes.
Okay, thank you very much. So the question maybe for my colleagues who don't speak Arabic is that frequently the diagnosis of diabetes is late, where the person already has pre-existing complications. So the timing of the duration of diabetes could be pretty late. I think what you're saying is very true, and we need to take two messages here. Number one is to try to be proactive and screen people who have the features of diabetes or simply by age. There is so many criteria for screening a person that we suspect, maybe family history, maybe features of obesity or metabolic syndrome, and certainly anyone above the age of 30 should be screened in our population and in our ethnicity. That's number one. Point number two, if I don't know the diagnosis of my patients, they come to me already with diabetes, then obviously I will have to assume that they had the condition for a number of years. Assuming 5 or 6 years of the duration is not far. So then you can factor for this. But still, even if it's 5 or 6 years that you would say, it's better than not knowing this, and better if we wait for complications for a person with now being diagnosed with cardiovascular disease or stroke or claudication. We have obviously to try to be proactive as much as possible. Thank you for the question.
Next question.
My question is to Ustaz Dr. Inass. What is your opinion of taking amino acids in treatment of sarcopenia?
I think this is only to be given in protein deficiency. But if the patient is eating balanced food, then there is no need for supplement, because supplements and overuse of supplements is hazardous. We know that. So if the patient only is eating unbalanced food with protein deficiency, we can give supplement, but measured amount, not to take, the bottle, taking many tablets of amino.
Sometimes taking amino acids in the treatment of CKD, sometimes taking amino acid in treatment of liver cirrhosis. What is your opinion of taking amino acid in CKD and liver cirrhosis?
For CKD, I leave my colleagues to answer. Professor Yasser here is a professor of nephrology, and for hepatology, I leave also my colleagues or my professors.
We advise in case of CKD.
Okay, but maybe in measured amount. Professor Yasser, and certain types of amino acids. But I'm I'm against overuse of amino acids because they can be hazardous, except if the patient is deficient.
In a case of liver cirrhosis, there is sarcopenia.
If there is sarcopenia,
Sarcopenia in liver cirrhosis. And
in measured
one of the
amounts, but if in liver cirrhosis, if the patient is having liver hepatic pre-coma, for example, you can't give protein. You should reduce protein intake. So this needs to be measured, not for overuse. I don't know. And you can give the nephrology
Sure.
and Professor Yasser also.
So I think before I bring my colleague, professor in nephrology, yes, the CKD issue, the evidence for protein supplements in CKD to slow down progression or to improve survival is a very small number of studies, and it's not standard recommended practice. Amino acids, there's a big study that's come out in acute kidney injury. Is different from chronic kidney disease. So there's no role for amino acid in chronic kidney disease, but there is some evidence that if you give it in acute kidney injury, it might reduce progression to CKD and may enhance recovery from acute kidney injury. But let's just have one comment, very short comment on CKD, so we can ask questions about the talks we have.
I can have a comment on this, and I have a question for Professor Inass, if you allow me.
Okay.
For CKD, I think Professor Mek, you agree with me that in the last guidelines of KDIGO recommended that below the age of below GFR of 30, supplemental amino acids in addition to protein restrictions. This is not, as you said, not for protein progression of CKD, of course, but as a supplemental in addition to restriction of protein, supplemental for very low amino acid or protein diet, below GFR of 30, of course. Not for progression at all. But the issue is in CKD is that supplemental in cases of intact kidney function, we do not recommend, as Professor Inass said, it is supplemental amino acids, for example, GEM or something like this. They are injurious for the kidney. They are injurious for the kidney. They may, you said supplemental amino acids.
Yeah.
Okay, not supplemental amino. This is what I get.
So do you think the three of us, can we meet after the session, the three of us? We can carry on the discussion, so we can get another
my question to Professor Inass regarding sarcopenia. Sarcopenia is, what about the degree of proteinuria on sarcopenia? Is there any relation or any data about the progression of proteinuria with advance of sarcopenia? And the other question is the effect of different drugs, anti-diabetic drugs on sarcopenia. Is there any effect of different drugs on progression or establishment of sarcopenia in diabetic patients?
For the effect of proteinuria, we need your insight later on to prepare a presentation maybe
I think
in the
it seems
next
to be
meeting.
logic, but I asked for data. I don't have data, I asked for this. It seems to be logic to have an effect.
Sure, thank you very much.
And the effect of drugs?
And the effect of drugs, we didn't study, I don't know, we didn't study this yet.
The high intensity of weight loss with some of the advanced GLP, GIP leads to muscle loss as well as fat loss. And that obviously can, in the specific age group, can worsen the problem. And that's why our recommendations for anyone to be treated with the powerful GLP or a combination of GLP and GIP is to do resistance exercise and regular exercise as well to try to counter the effect of the muscle loss. And also we should try to move from just simply measuring BMI to measuring lean body mass, because that is far much more effective of measuring the benefit. Because with some of these drugs you lose weight, but you also lose muscle and you lead to sarcopenia, which is something we'd like to avoid.
I would like just to add a comment on this very, very interesting question. One of the major pathologic entities, which is characterized by sarcopenia, as you all know, is heart failure. And in heart failure, we have none of all these conditions, but we have inflammation. So one of the situations that we face in diabetes, and Professor Shaltout has stressed this point, together with obesity, is the increase of pro-inflammatory cytokines. So it seems that part of future research, there are not much data on this issue. Sometimes I'm saying that we have to treat this with aspirin, but just as a joke. But it is true that the increase of pro-inflammatory cytokines can increase sarcopenia. This is the reason why resistant exercise, we have published a paper 10 years ago in Diabetes Care, we have shown that resistance exercise is the best, as you have mentioned, and in the guidelines of ADA is clearly mentioned for diabetics, as you all know. The second point I would like to make, together with aging, and you have, both of you in your talks have really stressed the point of age, is that with aging, cortisol levels increase. And here we have a discrepancy because cortisol should decrease inflammation, but on the other hand, inflammatory cytokines increase the production of cortisol. And cortisol, as you all know, is a very catabolic hormone. So we are in a vicious circle when we deal with this situation. This is why we're discussing that much about it. And I believe we must work a little bit more on how we can take down the levels of glycemia and glycated hemoglobin, as has been stressed in your talk, because this is the most pro-inflammatory situation in diabetes, to my view.
Okay. Yeah, sure.
Thank you for all the speakers. Actually, I enjoyed the session. My first question to Professor George about the biomarkers for gestational diabetes. You spoke a lot of cytokines, and probably it may not be the ideal solution in low-resource communities like Egypt. Did you come across reports about pregnancy-associated plasma protein A, which is routinely used by gynecologists for placental dysfunction early as a biomarker for gestational diabetes?
This is a very good question. Actually, Kypros Nikolaidis, which is one of the most known around the world scientists in UK, and is the guy who has introduced the PAPA test all over the world, has published one paper where he tried to measure visfatin and leptin in the early first trimester to find out whether it could be a marker of the possible development of GDM for the second trimester. But unfortunately, this came up with a specificity and sensitivity index around 70–75%, so it was not a good index. We have no other good marker regarding possible prediction. If I would like to advise which would be the best marker for the development of GDM, would be just measuring the weight of your patient. If the weight, yes. If you have a BMI above 28, I would say, which is a very important point, you have to take this weight down. This is the best marker.
Because you had a pilot research about pregnancy-associated plasma protein A as a biomarker, and it shows some good results. It may be a better solution.
There are many markers.
In low-resource areas, again.
There are many markers which have been advanced, but none of them has shown specificity and sensitivity enough to be used in every day. And another issue also is our women with PCOS, polycystic ovary syndrome, because they develop 4 times more GDM. So these patients, and I know that in Egypt there is enough of PCOS, one should pay attention to these two kinds, obesity, PCOS.
Okay.
Good, so we have another session starting soon. You had another question? Very quick question, please.
Actually, yes.
One
I had a
quick
question to Professor Hassanain about do you believe it is a good idea to develop parameters for age-adjusted parameters regarding everything, regarding the metabolic parameters, regarding the lipid parameters, regarding everything, thyroid parameters, because actually the normal in a 70-year-old person is not the same like 20 or 30.
Sure.
So we need to, the diagnostic criteria should be age adjusted.
Sure, and it's really the message I would like to share with everyone is, obviously we are all concerned as we get older about these conditions, but what we're trying to say is, don't ignore the younger person and get cheated by their young age thinking that they are low risk, because prevention of the problem or starting the treatment aggressively early enough will prevent these younger people from the condition. Equally, the older person need to be screened proactively and then treated proactively. Age is not a barrier for active treatment, whether it's blood pressure treatment, statin, or the right cardiovascular outcome trials data. When we saw the use of the SGL2 inhibitors and GLP-1 receptor agonists, specifically the SGL2, as we are aging, the use is getting lower. Although in theory, or in reality, the older person have higher rates of cardiovascular disease and higher rate of renal problems. But it does look like clinicians are reluctant to start these drugs for the older person, which is something that they need to change as well.
Great. So, ladies and gentlemen, it's a great pleasure to have chaired this wonderful session, which was delivered by eminent professors George Mastokorakos, Mohammed Hassanain, and Inass Shaltout, and my co-chair and myself were privileged to be part of this session. And thank you very much indeed for the interaction from the audience. Some of the discussions I see will continue through lunch, and it's always wonderful to end on such a note. Ladies and gentlemen, many thanks for your attention. Thank you.